pleasure being on this group. I'm Dr. Adimo Olusoya, and I'll be taking the practice question for today. Practice question number 1. The question: a 45-year-old woman presented to the emergency with a history of abdominal pain and bloody diarrhea. The symptoms are said to have started abruptly a day earlier. By midday of the same day, the presentation, she had passed stool about 10 times. She also had fever, anorexia, but no vomiting. On examination, she was ill looking with a temperature of 37.6 degrees Celsius, pulse rate of 88 beats per minute, and blood pressure of 120/80, with no postural drop in blood pressure, I guess. Abdomen was tender, but had no palpable masses or organomegaly. Bowel sounds were normal. The digital rectal examination revealed blood-stained findings. Question A will be, what differentials would you consider? What tests? And then that's question B. Question C is, what's the treatment? Question D is showing the results as listed, and then how would you treat the patient, and how would you like to also monitor her? So the answers. So let's start from the first question. What are the differentials? So looking at the question, the patient's the symptoms started abruptly, about 24 hours duration. There is fever. There is passage of stool, frequent passage of stool. That's 10 times in a day. In 24 hours, fever. There's anorexia, but there is no vomiting. And then the patient has fever. That's 37.6. But it's important to note that the pulse rate and then the blood pressure are still within normal limits with no assisted postural drop, like no orthostatic hypotension. So the volume loss is not yet critical. But of course, passing 10 stools a day is very significant. And then it's important that the DRE also confirm the findings of blood-stained fingers. So to the differentials of all these listed symptoms, I would like to start with number 1 would be gastroenteritis, which is due to Shigella and Salmonella because of the blood-stained finger on DRE. Another differential I'd like to give is an inflammatory bowel disease superimposed by probably an infection. We know that inflammatory bowel disease such as ulcerative colitis and Crohn's disease can actually give blood-stained feces in them, especially they have superimposed flare or inflammatory, if they have an inflammatory problem at that particular moment. And then another differential will be bleeding diverticulitis, which is a cause of a lower GI bleeding that will give the frank blood that we are seeing on the DRE with associated inflammation of the diverticuli in such patients. Another differential will be massive upper GI bleeding with maybe superimposed infection, probably from perforated peptic ulcer disease or chronic liver disease. But this is not likely because the other features of chronic liver disease were not given in the history. A differential there will also be food poisoning, which can account for the diarrhea that she has, but just straightforward food poisoning might not give that bloody DRE on a blood-stained finger on DRE. Also, another differential I thought of was bleeding hemorrhoids, but that won't explain the fever and then that this patient has had. So I want to see maybe, so those are some of the differentials I thought of. So the test I would like to do for this patient, as this patient is presenting due to the fever, I would like to do a full blood count for this patient to assess for white blood cell count, and then PCV, urgent PCV from that full blood count because of that blood-stained DRE. I like to do electrolyte urea and creatinine to assess for the renal function and electrolyte derangement, and then the kidney function in this patient. It's stool MCS to know what exact organism is actually causing this diarrhea in this patient. A urinalysis also to assess the kidney function of the patient. Once the patient is more stable, I would like to do a colonoscopy to assess the colon and if it's a structural cause of the bleeding, so that the diagnosis can be made, and if it can be surgically treated, it will be properly attended to. A liver function test, if I'm thinking of a massive upper GI bleeding due to CLD, just to be sure that there is no coexisting LFT liver problem in this patient. So an abdominopelvic ultrasound too will also be in place to rule out any structural or surgical cause or any other complicating problems that might occur in this patient. If it's more critical, I can go ahead to do an abdominal CT, but I want to start with the baseline of an abdominal pelvic ultrasound. And a fetal calprotectin can also be done to rule out malignancy. So this so if the next question is the treatment. So if this patient is presenting to me, this is actually an emergency. Passing test tools means that we are expecting electrolyte derangement in this patient, and such should be managed as an emergency. Patient should be appropriately resuscitated by immediately setting wide bore cannulas to rehydrate the patient, preferably with Ringer's lactate. We know that GIT losses causes a lot of hypokalemia, and in such patients, I would also want to give them 5% dextrose because of the risk of having hypoglycemia in this patient. So I want to be sure the patient's glycemic control is also optimal with fluids such as Ringer's lactate and dextrose. I would want to give broad spectrum IV antibiotics to this patient, antibiotics such as ceftriaxone or quinolones that can actually be beneficial. But I think can be beneficial in this patient. Analgesics or antipyretics can also be given. This patient has abdominal pain, has fever, so I want to give something to actually relieve that discomfort that the patient has. I would want to consider giving placing the patient on NPO, Neopa Oris, until I can ascertain that it's just straightforward gastroenteritis, especially because of that bleeding that the patient has at the moment. That's one of the reasons why I want to ensure that the glycemic control is optimal. Then when I've done this and the patient is much stable, I can now take a detailed history to ask why this patient, what exactly, and streamline my differentials in this patient, examine for dehydration. And then if there are surgical complications from all this, I would like to request for surgical consults to further assess and treat any complications that might occur if it's due to a surgical event, such as the bleeding hemorrhoids and then probably massive upper GI bleeding in this patient. So that's how I would like to treat this patient. So, but we also have to put in mind that the treatment is also based on the results that we have, which is showing hemoglobin of 12. The patient's PCV is still fairly okay, but we know that it's a possibility that by the time we rehydrate this patient, the PCV might drop further, and the patient might also need a blood transfusion. The white blood cell count is 21,000. So there's an ongoing infective process or an inflammatory process that is giving them reactive white blood cell elevation. The platelet counts are still within normal, but we need to closely monitor it with the serially, so that in case it drops and we need to replace. So you can see from the question that the sodium is low, 132, potassium is low, which is expected when you have passed about 10 stools in 24 hours. The urea is 8.1. The albumin is within normal limits, so it's probably not likely due to chronic liver disease in this patient. Stool culture revealed E. coli sensitive to ofloxacin and ceftriaxone. So that's one of the reasons why I would use IV ceftriaxone in this patient. So the next question is now, how are you going to monitor this patient? So monitoring is very important in this patient. You want to monitor the amount of stools the patient has passed. If it's not improving, you have to closely monitor the hydration status and rehydrate. The hydration should be commensurate with, especially with the hydration status of this patient. You want to check for skin turgor, check the buccal mucosa of this patient, and be sure that the patient is properly rehydrated. And then you do serial PCV, like I mentioned, to assess the need for blood transfusion in this patient. You repeat the full blood count. We expect that the white blood cell count should be on the downward trend because of all the treatments that we have given this patient. And then repeat electrolyte urine and creatinine closely to
you have 1 minute left. 1 minute
Okay,
left.
Okay, thank you. So you want to monitor the renal status of the patient, and then routine random blood sugar of this patient should be done, because we don't want our patient to have hypoglycemia. So that's actually the end of the answer. I saw a journal that I felt just mentioned some few things that we just need to know as pointers to most likely bacterial gastroenteritis. So gastroenteritis is inflammation of the lungs, and then we know that it can be caused by viruses, bacteria, or parasites. These are some of the common organisms that can cause bacterial gastroenteritis. And then we know that they produce different toxins, enterotoxins, exotoxins, and then they also affect by a mucal invasion, which is what most likely this patient has. The Shigella, the Salmonella are the likely organisms that are implicated when you have mucosal invasion that leads to production of blood in the stool. So this is some of the other points that I also felt worth mentioning, and the complications that can occur if there are sugar toxins, such as hemolytic uremic syndrome. Thank you very much.
Thank you so much, Dr. Omokorede, for that wonderful presentation. You're truly appreciated. Okay, so the floor is open to questions and contributions. Okay, so before we wait for questions and contributions, I just want to add a little, okay, to what you presented. Thank you so much. Okay, so now going back to the question. Okay, the question says, a 65-year-old woman presented to the emergency with a history of abdominal pain and bloody diarrhea. The symptoms were said to have started abruptly a day earlier. By midday of the same day of the presentation, she passed through about 10 times. She also has fever and an anorexia, but no vomiting. Okay, from my little understanding about gastroenteritis, about gastroenterology, once there's no vomiting, it's not called gastroenteritis. It's best you just call it enteritis. Enteritis is stooling alone. You understand? Okay, so I'm thinking that calling it gastroenteritis because there's no vomiting should be called. It's called enteritis instead of gastroenteritis. Then I was also thinking maybe it should have been acute inflammatory diarrhea, that's dysentery. And again, to looking at the history, we have causes of acute diarrhea and chronic diarrhea. So this is basically tilting towards causes of acute diarrhea. So the aspects of ulcerative colitis, Crohn's disease, I think those are causes of chronic diarrhea. This patient doesn't have that prolonged history of diarrhea. I think chronic diarrhea, I stand to be corrected, is when you have diarrhea lasting more than 14 days. I stand to be corrected. Okay, so I was thinking that differential should be tilted towards shigellosis, salmonellosis, entamoeba histolytica, those enteroinvasive E. coli causes of diarrhea, those Campylobacter, amoebic coli. So those gardiasis. So I was thinking to be more of that. Although you can still stand, but like I think it should be top. They should be placed on the top in the chart list, because this is more of an acute diarrhea. Then to add on to the investigations that can actually be done, for acute diarrhea, it's more of the viral causes. So we can actually add enzyme immunoassay. This can actually detect rotavirus. It can actually detect adenovirus antigens. And then also we can do what we call the latex agglutination assay. This one also helps us to detect when the cause is from rotavirus as well. Then also, I don't know if I heard, maybe I didn't listen properly, for stool culture, microscopy, and sensitivity. So this is just the few add-on I have to the presentation. Thank you so much. You did a very great job. Thank you. Thank you.
Thank you very much. The points are noted. Yes. I actually thought in line of what you were saying, but I felt okay, just to make the differentials to be bulky. So I grouped, and that's why I grouped it into as one course, and I listed them. So I just felt, will it fly with the examiner if I just list shigellosis, and would they now not count it as one differential? So that was why I just grouped everything on that one and then listed it. So I'll list just to show that, okay, I'm thinking wide. And then I was thinking for the inflammatory bowel disease, sometimes they can have an acute flare, though the background history was not given to us about the patient. So that was why I just listed it as my number 2 differential, because you know that if you see bleeding, you should think of an IBD. But I quite thank you for the other points, and I quite agree with some other things you said. And then still MCS is also here. It's part of the
Okay, thank you.
test that we should do. Yes, thank you so much.
Okay, thank you so much. Okay, so going over to the chat room, Dr. Afyon Basi is saying intravenous 5% dextrose will worsen the diarrhea. Then Musa Abubakar Umar is saying, thank you for the good presentation. Can we consider enteritis due to enteroinvasive E. coli as the cause? Dr. Abimpe is saying, thanks for the beautiful presentation. Additional investigation should include 2 fecal leukocytes. Okay, so these are the suggestions. Please, can we applaud her? Can we thank her for a beautiful presentation? Please, we need more. Please, let's applaud and appreciate her. Thank you. Okay, so these are the comments made in the chat room. So going over to
Thank you very
the
much.
electronic hand. Okay. I'm not seeing electronic hand up. Okay, going back to the chat room, there's another. Okay, Dr. Usman is saying thank you for the presentation. Okay, they're all applauding you for a beautiful presentation. So in the absence of questions from the participants.
Sorry, let me just, good morning. Sorry, I was looking for my electronic hand. Good morning. But I can't find it on my phone. I don't know what happened. Sorry, I had to just come in. Good morning, teachers. Good morning, everyone. Just a little contribution. Thank you very much to the presenter. You did very well. Now, for this question, I think it's very important that we look at the incubation period as well. It started acutely. So that means we're looking at something within 24 hours, at least 24 to 42 hours rather, and everything. And there was no history of weight loss, even though she's actually elderly. Would have been thinking more of like your IBDs and your malignancies and all of that, So so for this, like the coordinator said, that acute diarrhea, the duration is actually 14 days. Then above 14 days, you have chronic diarrhea and all of that. And the other forms of classification of diarrhea, because of time, I won't go into it. So for this, salmonella usually occurs between 24 to 72 hours. So, and they didn't tell us the environment, but I think that's, for me, in a way, with the high fever and all of that, we come top on the list. Then I'll think about, like someone said in the chat, and E. coli also is very important. Then, and the ones mostly implicated are the enteroinvasive E. coli and the enterohemorrhagic E. coli, the serotype 015 and HIT7, which is very important. And for this, we have to check the blood picture, because associated with hemolytic uremic syndrome, which consists of microangiopathic anemia, renal failure, and thrombocytopenia. So peripheral blood film will also be very important here. And we also need to also try to see how to culture the E. coli 0157. I think it's cultured on a very special media. I think is it Sabitor McConkey Ega or something like that. Then the PCR is also very important here. Then I won't find a colonoscopy is important, because of her age. She could also be having other things, and she could also have diverticulosis as well, infected, At that point, it can also come because of her age. She could have diverticular disease, which when it gets infected can bleed, and the other differentials that she mentioned. So I would rather like stabilize a bit before I rush her in, depending on the volume of blood she has lost, because you need to stabilize and make sure that she's hemodynamically stable. While inform also invites, it should also be like a multidisciplinary approach. You should use that approach. Then you try to bring in the gastroenterologist to come and review. You bring in the hematologist, you bring in the surgeon, depending on the volume of blood loss. Then when the patient is hemodynamically stable and you're not able to arrest, you can now also send for the surgeons to come and do a colonoscopy. You did not talk about what's it called, full blood. I mean, yes, you mentioned full blood count, but a clotting profile is also very important in this patients because you need to check. I don't know if you mentioned.
No idea. I just mentioned that liver function tests. I should have been more specific. Thank you. That's well noted.
Okay. So upper GI bleeding. Well, because ligament, upper GI bleeding is ligament bleeding above the ligament of Treves, which is in the small intestine. Then below is lower GI bleeding. When you begin to see red frank hematuria in the blood, it means the patient must have had hematemesis before you start seeing that it must be massive upper GI bleeding before you now begin to see hematochezia. And for me, the presentation does not typically look like it. So, like the other presenters, the other people, those that have spoken have talked, diarrhea is actually a very wide topic and you need to carefully choose. Is it a gastroenteritis we're talking about? I mean, a food poisoning we're talking about, because most of them, the incubation period is small. But from this, from the questions, from the question, it didn't really they didn't give us any clue towards that. So we need to, then we should also think about small intestinal bleeding, because for those ones, you can have what they call obscure upper, bleeding, from the small intestine. So if you have done everything and you're unable to pick anything, a capsule endoscopy may, but that should come down below your investigation as well if you're unable to pick anything. Let me stop there so that other people can contribute. Thank you very much. It was a wonderful.
Thank you so much. Thank you so much.
Thank you, Dr. Faith, for that beautiful input. We really do appreciate. Okay, so we have more comments in the chat room, so I will go through them. Okay, so Dr. Ibrahim is applauding you. Dr. Obase is saying thank you. So Dr. Olaleko is saying good morning. I think the following differential diagnosis should have been considered in the following order: acute infectious diarrhea, ischemic colitis, diverticulitis, pseudomembranous colitis, inflammatory bowel disease. Thank you for the wonderful presentation. The next person says, for the fluid, I think normal saline or Ringer's lactate. And the next person says, any place for stool anion gap and osmolality? Otomo Korede, any place for stool anion gap and osmolality? They're asking a question.
I think I'll leave that to the gastroenterologist.
Okay, so the gastroenterologist in the house, any answer to that? Any place for stool anion gap and osmolality?
Well, thank you very much. Well, when you are actually dealing with diarrhea, it's good to bring that in, but it's mostly with acute. Well, this is an acute diarrhea. It's mostly with a viral, because it's with. Sorry, I didn't talk about the viral. Most viral diarrhea, cause of diarrhea may not cause blood in stool. So it's actually, to me, well, you can actually do a stool osmolality, but it's mostly with acute watery diarrhea. So, but other gastroenterologists can actually, give an input. Let's see. It's not out of place.
Okay, thank you so much. Thank you so much. We really appreciate your comments. I don't know if you have any other contribution to that particular question. Okay, otherwise I go to the next question. Did you mention ORS and zinc? Dr. Mokorede, you're being asked.
No, I didn't. Because of the bleeding, I would want to be careful with oral intake so that it's not worsen the bleeding. So the bleeding is why I want to be careful with oral intake, and I'll rather use intravenous glycemic control. Let me just put it that way. Just because of that bleeding. So it's not just a straightforward diarrhea anymore. It's a complicated one. So I have to be very careful with oral intake.
Okay, thank you so much. Okay, so thank you. Gastroenterologists do colonoscopy too. So just like an additional thing, not only surgeons. So they do colonoscopy too. Okay. So every other person is applauding you for a beautiful presentation. Okay, so in the absence of questions and further contributions from the participants, I will please want to move to our chiefs. Thank you so much.
Guys up, Dr. Good. Yes, another person was up earlier.
Dr. Kalamama.
Okay, ma. Okay, I'm just seeing their hand up now. Okay, thank you, ma. Okay, Dr. Godi, Dr. Godia, please can you speak up? Thank you.
Yeah, thank you so much. Thank you so much. Good morning. Thank you for the presentation. I just want to give a little comment about these two fecal osmotic gaps so that we have a clarity. So mostly it's indicated when we want to differentiate watery diarrhea from osmotic diarrhea. Sorry, secretory diarrhea from osmotic diarrhea. So generally diarrhea can be classified into watery, inflammatory, we have fatty diarrhea and the other ones. So watery diarrhea is further divided into two. We have the osmotic and secretory. We do the fecal osmotic gap to differentiate between the two. When we have a fecal osmotic gap of less than 50, we say there is a secretory diarrhea. When it is greater than 50, or some we say greater than 100, and we say it's an osmotic diarrhea. Thank you so much for the presentation.
Thank you very much, ma.
Thank you, Dr. Godia. You're well appreciated. Our gastroenterologist in the house. Okay, Dr. Momodu, I saw your hand up earlier on. Dr. Momodu.
Thank you so much. I also wanted to speak about that. She's done that. Thank you, ma.
Okay, thank you. Thank you so much for your inputs. Thank you. Okay, so in the absence of, did I see something else? Okay, stool osmotic gap can help to rule out malabsorption syndrome that can come from diarrhea. So please take note. Stool osmotic gap can help rule out malabsorption syndrome that comes from diarrhea. Thank you. So in the absence of further contributions and questions, I'll please move to our chiefs. Thank you once more. Thank you.
Okay, thank you, Dr. Kalamama. I must appreciate the speaker. Yeah, she kept to time and she was eloquent. A question too, she went straight to the questions and answered. Please, what you do for us is kindly rearrange the differentials you were given. And please, so that before you upload on the platform, so those, if this is recall, I think this thing was calling from the national exam. So as I always see, none of the exams are useless. Don't feel good. You are for a particular college, you won't listen to the other college. You never can tell. Sometimes they they get similar questions borrow questions from their sister colleges and utter it delete you. So all questions are important. Then I want to call on our Chief Cookie. She's our gastroenterologist. Let her just sum up and I don't know if there's anything she needs to add. Chief Cookie, ma.
Hello. Sorry, before Chief Cookie talks, I just wanted to note one particular thing she said while she was presenting. She talked about broad spectrum antibiotics. Then she now mentioned ceftriaxone subsequently. I don't know if I don't think it's broad spectrum she should be talking about when she's talking about an acute diarrhea. It should be an antibiotic that has more gram-negative coverage, not broad spectrum. Okay, so I think that's just one thing I wanted to note.
Okay. Thank you very much. That's a better way to put it. Thank you. Oh, thank you, sir. Chief Cookima, any comments? Okay. See me, our dear Chief Cookie is busy. So thank
she's
you.
Not on the phone.
I saw her. She's on the call. I think she's busy. So thank you so much, presenter. Thank you all those that commented, the gastroenterologist, Andrew, Dr. Godia, Dr. Faith. Thank you so much. And every other person that made one or two comments, those that ask questions, we appreciate your active participation. Dr. Kalamama, I think we can take the next. So once again, thank you, Dr. Thank you. The presenter. Thank you so much.
Thank you. Okay, thank you so much. Okay, Dr. Felinda.
I saw Dr. Mamza's hand up. Has she spoken?
Okay. Chief Manza. Okay, thank you, ma. Okay, thank you.
Chief Manza, can go ahead, ma. Network is breaking. I don't mind, your network is breaking. Can't hear you.
Good morning, everyone. Dr. Good morning. Thank you for the presenter. Okay, good morning. Can you all hear me? Hello, good morning. Hello, hello, good morning.
We can hear you now.
Can you hear me? You can hear me. Hello, good morning.
We can hear you now.
Hello.
Good morning. We can hear you now.
Okay, okay. Good morning.
Good morning, Chief
everyone.
Manza. We can
Good
hear
morning,
you.
Doctor. Okay, good morning, Dr. Good morning, Dr. Christopher. Okay, well done for the presenter. There's something there's something I also want to correct. Somebody has corrected the issue of gastroenteritis and enteritis. It's when somebody is vomiting and that the causes of enteritis are the things that cause the food poisoning. So you look at the duration period when the patient is presenting, usually between days 3 to 5 days are things that can cause food poisoning. Then those things that you mentioned, salmonellosis, E. coli, Campylobacter, can be a cause of food poisoning. So you should not separate food poisoning from gastroenteritis. Hello, sorry, I lost the call. I don't know whether you heard me. I was locked out temporarily. Hello?
Hello, ma. We can hear you, ma.
Hello, I don't know whether you heard me. I concluded, then I noticed that I was locked out. So I didn't know I was speaking to myself.
Ma, can you please just recollect about, you were saying something about salmonellosis and shigellosis not being separated from food poisoning. We
So
didn't get
based
that
on
point
her
very well.
differentials, yes, based on her differential, first she said gastroenteritis, then she mentioned the causes. Then another one, then she separated and said food poisoning. So I want to draw our attention down. By the time we are mentioning gastroenteritis, we can say secondary to food poisoning, then we list the infective and the other things that can give that, especially the infective causes, the bacterial ones that can give the food poisoning. Food poisoning should not be a separate differential diagnosis. So salmonellosis, E. coli, and the staphylococcus bacillus can be, they are usually the causes of food poisoning. So when you mention enteritis, secondary to food poisoning, you think is the cause of the food poisoning. That's what I want to correct that. Thank you.
It's well done.
Sorry, my network
very much. I had
bad.
I'll make the correction.
I don't know whether you've had.
Yes, I had. It was loud and clear, ma. The point is noted.
Okay, thank you so much. Thank you so much, ma, for that wonderful input. Okay, so move on to the next presenter, Dr. Afelinda, who is going to be taking us on practice question 9. Dr. Linda, please have the floor. Thank you.
Okay, good morning. Thank you. Good morning, assistants. Good morning, colleagues. Thank you for the opportunity to take this question. That's practice question 9. Okay, it's not moving here. Jesus. Okay. So the question, okay. The question is, a 26-year-old man who recently traveled to South Africa where he had unprotected sex presented to the clinic with painless penile ulcer with inguinal lymphadenopathy. One, mention 5 differential diagnoses starting from the most likely. What is the most likely organism causing the disease? Mention 4 investigations to make the diagnosis. Then mention drugs we can use to treat the condition. What other investigations will you do to the patient? 6, how will you prevent the spread of disease? So mentioning 5 differential diagnoses, starting from the most likely, I think I have primary syphilis, where there's a painless ulcer, and also they present with painless lymphadenopathy. Then granuloma inguinale, the ulcer is painless. However, there's no lymphadenopathy caused by Klebsiella granulomatis. Then lymphogranuloma venerum, also called LGV, causes painless ulcer. However, there's painful lymphadenopathy. Then there's chancroid that comes with painless, painless ulcer with regional, painful ulcer with regional lymphadenopathy caused by Haemophilus B. Then HSV, here HSV 2, but usually because now there's both HSV 1 and 2 because because of the practice of oral sex, so we think of HSV 1 and 2, which causes also painful ulcers. So what is the most likely organism causing the disease? I think it's Treponema pallidum, subspecies pallidum. For investigations to make the diagnosis, I can do a dark field microscopy to view the organism. Then the non-treponemal test, which is the VDRL, and then the RPR reagent test. It's estimated to be sensitive in detecting primary syphilis, about 78 to 86%. However, in secondary syphilis, it's 100% and 95%. Sorry, in detecting tertiary syphilis, about 95 to 98%. If these VDR RPR are positive, I'll go on to do a treponemal, specific treponemal test, which I'll either do the fluorescent treponema antibody absorption test, which is the FTA-ABS, or the treponema pallidum chemoglutination test. These are said to be more sensitive than the other treponemal test. Then I can also go on to do the preliminary chain reaction. So which mentioned drugs you can use to treat the condition. I divided them in classes. I can use the penicillins, which include benzathine, penicillin, protein, penicillin, amoxicillin, then the tetracyclines, which include doxycycline, macrolides as the mycin or erythromycin, and I can use ceftriaxone. What other investigations will you do to the patient? I can culture the wound swab to rule out other causes of genital ulcer. Then I can
Okay, Dr. Afelinda.
see, I can also do multiplex PCR to also rule out other causes of genital ulcer. Then how will you prevent the spread of disease? I can do contact tracing. It is recommended that attempts be made to identify and trace other at-risk sexual contacts. And for primary syphilis, contacts within 3 months, in addition to the duration of symptoms that the patient is presenting. Then the others, okay, for secondary syphilis, contacts within 6 months, plus the duration of symptoms, and then within 1 year for early latent syphilis. Then all long-term partners of patients with late syphilis, all of them should be offered investigation. Then I can do a preventive treatment of all sexual contact within 90 days preceding patient's presentation of early syphilis if the serological tests are not immediately available. So all their contacts within 90 days, if I cannot get the test or in place that is that I don't have access to investigations or follow-up. Then I want to quickly talk about syphilis following this outline. Then it's an infectious disease caused by the spirochete Treponema pallidum subspecies pallidum. It is mainly acquired through sexual contacts. However, we can have the vertical transmission where there's congenital syphilis. Untreated can go on to form secondary syphilis, tertiary, and latent, and then congenital one. Basically, the epidemiology peaks at the height of sexual activity within 20 to 29 years, generally, frequently more in the LGBTQ community, where men who have sex with men community is higher there. And then said that males with primary and secondary syphilis outnumber females 10 to 1, basically because it's thought that males tend to present with the ulcers more outward. However, more like it's more on the outside. However, females tend to have these ulcers and usually painless within the cervix and endocervix. So primary infection is goes usually unnoticed. It's prevalent in people with of minority race and also those of socioeconomic class. And the co-infection is high with HIV, and like I said, males with people who have sex with men. Pathogenesis is basically penetration of these bacteria into the mucous membrane through microdermal abrasions. Where there's primary syphilis occurs within 10 to 90 days of incubation. There's local infiltration into the local lymphatic infiltration, which causes regional lymphadenopathy. Primary syphilis can also go on to left untreated. There's dermal infiltration of leukocytes and macrophages and lymphocytes, causes endarteritis, periarteritis, which causes necrosis and ulceration of the dermal arteries, and then causing this painless button-like chancre. It goes on, if it goes on untreated or unresponsive to treatment, goes on to secondary syphilis within weeks to months after primary syphilis, where the spirochetes now multiply and spread throughout the body, causing very myriad of clinical presentations. And then also left untreated or unresponsive to therapy, can go on to have latent syphilis, where the person is seroactive, however, there is no active or clinical manifestation. This can go on to form tertiary syphilis. So basically, I've said this, latent syphilis, like I said, the features of have resolved. So the patient is reactive in this stage. Then syphilis and HIV co-infection, acquisition increases with risk of HIV, increase the risk of HIV acquisition by 2 to 5-fold. And it's more efficient, increases the acquisition by 2 to 5-fold. Basically what happens first is there's a genital ulcer which disrupts the mucous membrane, making it vulnerable for penetration by HIV. And then genital ulcers also bleed easily during sex, increasing the risk of viral transmission. And then these genital ulcers also attract CD4 cells to the surface of the ulcer, increasing targets for HIV to infect. Then the risk, the risk of behavioral risks associated with acquiring syphilis is also increases the likelihood of acquiring HIV. So clinical presentation, usually it comes with a single indolent ulcer. However, those who are infected with HIV can come with multiple ulcers, which are painless, indurated ulcer, 1 to 2 cm in diameter with regional adenopathy. And also this regional adenopathy is painless. It's usually rubbery and bilateral. And the onset of time ranges from 10 to 90 days, averages within 3 weeks of exposure. Asymptomatic individuals can be unrecognized at this stage, especially for women or men who have sex with men, that can occur within the endocervix or within the perianal or within the rectal areas. So this is a picture. So secondary syphilis occurs within when primary syphilis progresses, left untreated or unresponsive to management, occurs within 2 to 10 weeks after primary chancre, and there's diffuse extensive maculopapular rash.
You have 1 minute left.
Okay, so we can have cutaneous manifestation, diffuse maculopapular rash, including the palms and soles. We have moth-eating alopecia, condyloma lata, which looks like a condyloma acuminata. Then we have the secondary syphilis. The person can become Malay headache, anorexia, and then they can actually also come with a similar chancre to the primary chancre. Then here, almost all of the treponemal tests are positive here, and also even for the non-treponemal are very positive. We can have GI involvement where they can come with hepatitis, they can have proctitis, they can also come with optic neuritis and nephropathy, apart from the apart from the cutaneous manifestation. Then there's malignant or malignant syphilis, very rare but aggressive form of syphilis found in HIV patients. they have severe manifestation. Then okay, secondary syphilis, latent syphilis. Okay, there's no latent syphilis. There's no clinical manifestation. Tertiary syphilis, there's cardiovascular, neurological manifestation. Then the rheumatoid syphilis, where it infiltrates every organ. And then we have the congenital syphilis. Evaluation of the microscopic. We can do the dark field examination. It doesn't. Okay, dark field examination. We can do polymerase chain reaction for syphilis. Then the non-treponemal tests, which include the VDRL, and then the rapid plasma reagent tests. They are screening tools for syphilis. But of course, the VDRL, we know that they are basically detect IgG and IgM antibodies to the patient's cardiolipin. So we can have false positive tests in leprosy, in connective tissue diseases, you can have false positives. And then, so if it's positive, you can go on to do another, non-treponemal test is the unheated serum reagent test we can do, but it's the VDRL and the rapid plasma reagent are much more sensitive than the unheated serum reagent, and so it's not used routinely. Other treponema antibody tests include the fluorescent treponema antibody test, the treponema pallidum particle anti-glutination antibody assay. Then we have the treponema hemagglutinin assay. Then we have the chemiluminescent assay. We have the enzyme immunoassay, IgA immunoassay as well. Can do reverse sequencing. Then there's also the rapid point of care tests for syphilis. Syphilis usually available where without the need for high-tech equipment. All patients with syphilis should test for other STDs, particularly HIV. So for our consumption and read the sensitivity for the other tests and the other STDs. Differential diagnosis for penile ulcers, for other STIs I've mentioned earlier. For we can have for women though, we can have cervical ectopic. Then, all right, thank you. Thank you. Treatment is basically penicillin. We can do doxycycline, ceftriaxone. Thank you very much for your attention.
Thank you so much, Dr. Afelinda, for that extensive presentation. A job well done. Okay, so the room is open to questions and then contributions. So while we await questions and contributions from the participants, okay, I just have like few questions to ask. Okay, so I want to find out how long does it take to completely kill the syphilis, that's the treponema pallidum organism? Like how long would you have to treat to say, okay, you have treated against the organism causing syphilis? Okay, Dr. Afelinda.
Okay, so from what I'm aware, once you give, I'm not very sure, but once you treat for the early syphilis, once you give the antibiotics, you can follow up at 3 months. You can follow up at 6 months to come to do the both the that's the non-treponema antibody tests to see if they are still elevated or not. And if they're still elevated, I think you can still treat, but that's the follow-up. But usually after treatment, they are usually responsive. I don't know, I can't say within how many days, but I know that you follow up within 3 months and then within 6 months to do the non-treponemal test, since they are the ones that that you can find titers for the treponemal specific antibodies. Those ones are there for life, so you cannot use them for follow-up.
Okay, I don't know. When I checked up, I saw 2 weeks. So I think the medication should be given for at least 2 weeks. You understand? Then you can see to an extent it has completely killed the treponema pallidum. I stand to be corrected.
You didn't say extent and duration of treatment. You said how long does it take to be cured?
Okay,
so
all right.
Thank you very much.
All right, thank you. Then, okay, so that's all. Okay, so I'll go to the chat room. Okay. Okay, so everyone is applauding you for a beautiful, lucid, detailed presentation, excellent presentation, extensive presentation. Okay, so you have to see questions. You have to see questions. Let me see any electronic hand. I didn't see any electronic hand. Okay, so everyone is applauding you. No questions yet. Everyone is applauding you for a beautiful presentation. Okay, so Dr. Maduka, you can please have the floor. I can see your hands up. Dr. Maduka, yeah.
Good morning, everyone. The question you asked about how long before you say that the treponema has been taken care of. Apart from treating for 2 weeks, you don't just treat for 2 weeks. But like she said, you have to monitor with the non-treponema investigation, the VDRL and RPR. And it is expected that you notice a 4 times drop, okay, in the level of either the VDRL or the RPR, compared to the initial screening. So that also gives you that confidence that you probably may have taken care of the infection. Thank you.
Thank you so much. Thank you so much. Okay, Dr. Momodu, you can please have the floor.
Thank you so much. Good morning, our teachers and colleagues. So, Chief Linda, it will also be very, very apt if you can help us with some of all these diagnostic algorithms for syphilis, most especially since we know that for those who have prior history of syphilis infection, it is quite unuseful or it won't be of diagnostic importance in using troponemal test to start with them since they are likely to remain positive for life. So I don't know if you can give us some, maybe in addition to your slides, for those who have syphilis without prior infection, how we typically will go, maybe with the non-troponemal test, then moving towards the treponema test. Please, I think that would also help. But then they also say that for those who have primary syphilis, who were able to be treated promptly, they tend not to have that treponema positivity for life. So in such situation, just kindly help us with some algorithms that will help us in our diagnosis. Thank you.
Okay, thank you, Dr. Momodu. Well, okay, what I know that is that once you've had syphilis, the treponema antibodies are there for life. So I don't know, maybe you could share your
studies have shown that those that are treated early with the primary syphilis might not have that positivity of treponema for life. Yes.
Might not, they don't.
If treated early.
I'll check it. Thank
there
you.
are lots of studies that say that. Then the algorithm for people without prior infection, let's just have how to manage them or diagnose them in that light. Thank you.
Okay. I actually included an algorithm just down below for the WHO algorithm for genital ulcers. I hope that will also be useful. I will also add that. Thank you.
Thank you so much, Dr. Momodu. Okay, Dr. Awal, you can please speak up.
Thank you very much, Dr. Linda. Thank you, Dr. Kalamama. Mine is, I just need a little clarification, especially from Dr. Kalamama, when he said treatment for 2 weeks. With what?
With doxycycline. That's what I saw. But I stand to be corrected. What I saw was it takes 2 weeks to completely kill the syphilis. But like what they further went to say was that at least the patient should be treated for 2 weeks. The patient can actually go beyond that, but at least should be treated for 2 weeks. Just what I saw. That's why I brought it up. Thank you.
Oh yes, I just want to say, like, we know the ideal drug of choice is benzathine penicillin, where you give a single dose of 2.4 million units, 1.2 in each Botox. It is when patient is allergic to penicillin that is when you start considering doxycycline. But I think generally treatment for syphilis, it's best to say benzathine penicillin because that's the old treatment and it has been like that and it has been sensitive since then. And because the dose that is given, the start dose, is just enough to, be there in the circulation for up to that 2 weeks. That is the reason why you can give the single dose. And the doxycycline cannot take that time. So it is when you give doxycycline that you talk about the 2 weeks. Alternatively, cephalosporins also can be used, like she said. Thank you very much.
Thank you so much, Dr. Awal, for that beautiful input. Thank you. Okay. Any more? Okay. Dr. Ekele Roberts, please, you can have the floor. Thank you.
Oh, said. I think that's like so the main
Sorry, I cannot hear Dr. Ekele. Maybe
benzathine penicillin 2.4 million units single dose, but if patient is allergic, can I use those cycling for both? Hello, can you hear me now? Can you hear me now?
Yes, we can hear you. Yes, Ekele, I can hear you.
Florence, can you hear me? Okay, so I don't forget to add that apart from the cycling, you can also use azithromycin 2 grams start. Okay, azithromycin 2 grams start. I just wanted to add that. That's for those who are allergic to the penicillin. So if not, just a start dose of the penicillin. That's the first line treatment. Benzathine penicillin. If you don't have benzathine, you can use procaine penicillin, but the first line is benzathine penicillin. Thank you.
Thank you so much, Dr. Ekele. Thank you. We really appreciate your beautiful inputs. Okay. Dr. Momodi is saying, please, what is Jarisch Hema reaction? Jarisch Hema reaction.
Jarisch-Hexamer reaction. So Jarisch-Hexamer reaction is a severe reaction that occurs in people. It's a phenomenon really basically that occurs when within 24 hours when you begin to treat syphilis, where the person comes with may come with fever, malaria, and okay, I said it. Am I audible?
Yes, you are. Dr. Momodu, are you okay with that? All right. Okay, so in the absence of further questions.
Sorry, I'm fine. Thank you.
Okay, thank you. Okay, so move on to our chiefs. Thank you so much, everyone. Move on to our chiefs, please.
Oh, thank you. Thank you, Dr. Linda. As always, you delivered. You always deliver in most presentations you are given. Thank you so much. This topic, I give it to you deliberately, a deliberate attempt. Usually don't give specialists a topic, but I had to give you this topic because I know you're going to do justice to it. The topic was a little tricky, so I needed you to handle it, and I'm happy you did a good job. And then Dr. Awa, thank you for coming in to contribute. Dermatologists, really, I want you guys to keep speaking. I know Ifoma used to be quite active, but for some time we haven't heard her voice. But Ifoma, please, we need to be hearing your voice, please. I know the other dermatologists in the house. Let's not look for you when they are doing dermatology presentation. Just the way when they are doing, I must appreciate Dr. for that. He's always picking up. Thank you. Please, want to hear more of your voices. Thank you so much. Then for the questions, the Darius-Hezma reaction, as they check on them while they are dying, they release some molecules that stimulate some cytokine cascade, really. So the patients that are having symptoms that looks like the syphilis is getting worse, it looks exacerbated, and such patients, really, all you have to do, just monitor them. not all patients, a common complication of treatment, because they are depending on the volume, the load of the treponema infection. Those that have high load, obviously they are more prone to having it. Those that don't really have so much, so they're really not prone, but just manage them, they'll be fine. So once it's something we usually expect to prepare the patient mind for, and once it's present, we quickly manage the patient and they do well. Then for those, as Dr. Awa said, benzathine penicillin is the drug of choice, really. It's the drug of choice for the treatment of syphilis. Other drugs are alternative. There are some conditions that you do not give other drugs, like neurosyphilis, pregnant women, children with syphilis. You must give them benzathine penicillin. Then those that react to, even those that react to benzathine penicillin and they have this neurosyphilis, you prepare them and still give them benzathine penicillin. That's how powerful drug is. So other alternative really is not just doxycycline. Tetracycline is there, azithromycin, even ceftriaxone. They also come in, but doxycycline is more tolerable. It's more tolerable for patients. So that's why most time it's like the likely options. But please, what Dr. Awa says stand. Benzathine penicillin is a drug of choice for the management of syphilis. So once again, I must appreciate the two speakers today. They did wonderful ladies, eloquent.